Right, this is your ophthalmology educator Dr. Manish Chhabra, and I am here to discuss images, one-liner questions, previous year questions, as well as some clinical case scenarios. This session is going to be that of approximately 1 hour duration, and it is my pleasure to let all of you know that we are holding one face-to-face revision set of sessions starting from 10th of December, where we have a faculty lineup of Dr. Pritesh sir, Dr. Neha ma'am, Dr. Ankit sir, Dr. Vid sir, and Dr. Kamal sir, and myself. So it is our effort to help you complete and able to revise whatever you have read so far during your course of preparation, and trust me, you will be able to easily score 200 plus marks once you will be through and through these sessions. These sessions are very thoughtfully planned for you guys, and these are going to be your face-to-face sessions, the full day sessions. Like my session is on 19th day of December. Similarly, different faculties are going to take different sessions. So our effort will be to motivate you, to show you the most common MCQs, to help you revise the most common topics, not only PYQs but also PYTs. So PYTs is previous year topics, so that during nth hour you are able to go through and through, right? So this is our effort, boys and girls. So with this, today I am going to give you a small preview of what I am going to discuss. My session on 19th of December will be a complete 9 to 10 hour session. So I have taken few points from that session, and I am going to concise it in this 1 hour. But to be able to do the entire ophthalmology, you will have to come face to face to attend that session, right? Okay. Hi Dr. Mansi, hi Dr. Tushar, and with this, so I am going to start. So nothing to write. This annotated, or should I say this already written PPT will be available to you guys, but I would want all of you to constantly interact with me. तो आप लोगों को साइड बाय साइड मेरे साथ इंटरेक्ट करते रहना है. तो यहाँ पे हम इमेजेस भी डिस्कस करेंगे, PYTs भी डिस्कस करेंगे, PYQs भी डिस्कस करेंगे, वन लाइनर MCQs को भी टारगेट करेंगे, और एक ओवरऑल हम आपको ओवरव्यू देंगे कि हाउ टू अटेम्प्ट द MCQ, राइट? Okay, hi Dr. Vishwajit, hi Dr. Abhishek. Dr. Abhishek, this is a preview. This is just one online session to give you an idea what's in store for you in the face-to-face sessions that we are going to start from the 10th day of December. As I've told you, there's an entire faculty lineup. So different subject faculties will be teaching you, will be helping you revise. वो भी faculties भी आपके साथ पूरी मेहनत करेंगी आपको FMG जो लास्ट पुश चाहिए होता है वो देने में. Okay, this is online session, 1 hour session, but the entire 9 to 10 hour ophthalmology session is lined up for 19th of December. Okay, now without wasting any more time, let's start. So I want all of you to actively participate in this session, and this is the beauty of live class. This is a sort of a virtual classroom, और मैं ये चाहता हूं कि आप मेरे साथ मेहनत करें. इस 1 घंटे में हम कोशिश करेंगे कि जितना मैक्सिमम हम कवर कर सकते हैं उतना कवर करें, राइट? तो तैयार हैं? ऑल राइट, सो लेट्स स्टार्ट विद अवर वेरी फर्स्ट स्लाइड. एवरीथिंग इज रिटर्न, इट विल बी इन द फॉर्म ऑफ एनिमेशंस. सो आई वांट ऑल ऑफ यू टू इक्वली पार्टिसिपेट एंड आंसर. तो तैयार हैं? यस, एवरीवन गिव मी अ थम्स अप इफ यू ऑल आर रेडी, स्टेडी एंड यस. Please let me know, Dr. Tushar, Dr. Mansi, Dr. Vishwajit, Dr. Abhishek. Yes, all of you guys and many other students. who are online but they are not responding. Yes, all right, chalo start karte hain. Now let's start. Which sign do you see? This is your PYQ, boys and girls, and in which condition do you see this? Can you appreciate something like this yellow arrow which is pointing towards something hanging down from the base of the orbit? And boys and girls, what is that? That is your typical teardrop sign, and teardrop sign is seen in fracture of the floor of the orbit. Yes, so are we done with this? So this is your most commonly repeated X-ray in FMG exam, 3 times repeated, and also in your NEET PG exam, 1 time repeated. There are high chances it will get repeated again. Yes, very good. Teardrop sign, wonderful. And orbital floor fracture, and the other name of this is blowout fracture. Okay, all right. Now a 65-year-old diabetic female with history of upper tooth extraction done 2 weeks back. Yes, what is the most deadly complication? So first and foremost, look over to the image. ये image देखेंगे, image देख पा रहे हैं? तो ये image में क्या लग रहा है? ध्यान से देखो, ध्यान से देखो. You can appreciate that there is periorbital edema, there is conjunctival congestion, conjunctival chemosis, there is pupil which is mid dilated. So but the examiner is not really interested in knowing the diagnosis. The examiner wants to know which is the most deadly complication. So पहले तो diagnosis बताओ, क्या diagnosis है इसका, boys and girls? This is your orbital cellulitis. Yes, now once you know that this is a case of orbital cellulitis, what are the keywords? 65-year-old diabetic, more common in diabetes, females, and history of upper tooth extraction, and it was done recently. So it all goes in favor of some infection which has entered into the orbit. How? From the upper tooth extraction to the maxillary sinus, from the maxillary sinus to the ethmoid sinus, to the ethmoid sinus into the orbit. Yes, now the most deadly complication of this disease is cavernous sinus thrombosis. This is your PYQ. All right, cavernous sinus thrombosis. Now can you tell me the treatment of orbital cellulitis? बता पाएंगे? What is the treatment? If you know the etiology, you know the treatment, and the etiology is most common organism, staph. Or yes, now can you tell me the drug of choice which is given in orbital cellulitis? It is your vancomycin. It is your vancomycin, and you will top it up with 3rd generation cephalosporin. Yes, so the drug of choice is vancomycin. Mind you, it is intravenous vancomycin. Intravitreal means inside the eye, injection inside the eye nahi denge. It is intravenous vancomycin and 3rd generation cephalosporin. चलो एक और क्वेश्चन पूछ लिया जाए यहाँ पर. Now if the patient has got cavernous sinus thrombosis, you know cavernous sinus thrombosis of the right side is in communication with the cavernous sinus of the left side. So cavernous sinus of the right and left side, they are well connected with each other. Now how will you suspect if the infection has entered from the right side to the left side via the communication? Just by looking over here. यहाँ पे देखेंगे, I'll just get on the side. अब देखिए यहाँ पे आप देख पा रहे हैं, what is this? This is your cavernous sinus, and can you appreciate that there is one nerve which is passing through the center of cavernous sinus? देख पा रहे हैं? I'll just shift here for better viewing. तो यहाँ पे देखिए, there is one nerve which is passing through the center of cavernous sinus. Now since this nerve is passing through the center of cavernous sinus, if there is involvement of this side of the cavernous sinus, this nerve which is passing through the center will be the first nerve to get involved. Yes, now since it is getting involved first, so this nerve is abducent nerve. Now because this is abducent nerve and it supplies the lateral rectus muscle, so the earliest sign that you see on the involvement of the other side of the cavernous sinus clinically is your abduction defect. Why? Because the abducent nerve will get involved. Abducent nerve supplies lateral rectus muscle, and lateral rectus muscle causes abduction. So the patient will have difficulty in abducting the normal eye. That is what I have written here. Earliest clinical sign of involvement of the other side in CST, cavernous sinus thrombosis. Boys and girls, that is your abduction defect. You already know abduction means outside movement. If there is a defect, the eye will not be turned outside, and adduction means inside movement, right? And it is due to involvement of the sixth crane. Very good, Dr. Rajvardhan. Very good. Very nice. Very nice. All right. So now, if you know the etiology, you know the treatment. Most common organism is Staph aureus. So the treatment is vancomycin plus third generation cephalosporin. But what is the treatment of CST? As the name suggests, Shakespeare बोल के गए हैं. नाम में क्या रखा है? मैं क्या बोलता हूँ? नाम में ही सब कुछ रखा है. Cavernous sinus thrombosis means there is a thrombus in the cavernous sinus. How will you treat cavernous sinus thrombosis? By giving something that can dissolve the thrombus. That means you will give intravenous something that can dissolve the thrombus. And what is that something? Tissue plasminogen activator, or even you can give low molecular weight heparin. You will give thrombolytics. I hope now it is clear. So thrombolytics are given. Okay, so you know the most common deadly complication is cavernous sinus thrombosis. The earliest sign of the involvement of the other side is, मेरे साथ बोलेंगे, abduction defect. The drug of choice is vancomycin third generation cephalosporin, and the treatment is your IV tissue plasminogen activator. Done? All right. चलिए आगे. Now can you tell me which tests are these? Yes, quickly. So first test, what is this test? So this is your forced duction test. This is your PYQ. So what do we do in forced duction test? समझेंगे ध्यान से. देखो क्या होता है. If the eyeball has turned outside, when the eyeball has turned outside, it can be due to two things. One, that there is paralysis of the medial rectus. Yes, or there is fibrosis of the lateral rectus. समझ में आया इतना? Now I want to diagnose whether it is due to paralysis of medial rectus. Why? Because eyeball remains in the center, because medial rectus medially खींच रही है आंख को, lateral rectus laterally आंख को खींच रही है, तो दोनों का एक्शन कैंसिल हो जाता है, तो जो आंख है वो बीच में रहती है. अगर मीडियल रेक्टस का पैरालिसिस हो जाएगा तो जो आई है वो बाहर की तरफ हो जाएगी, तो इसको हम बोलते हैं एक्सोट्रोपिया. तो एक्सोट्रोपिया हो गया क्योंकि आंख जो है बाहर को एक्सोडिविएट कर गई. समझ में आया? अब एक कारण और हो सकता है, अगर मीडियल रेक्टस इंटैक्ट है बट लेटरल रेक्टस मसल का फाइब्रोसिस हो गया, कॉन्ट्रैक्चर्स हो गए, तो लेटरल रेक्टस कॉन्ट्रैक्ट होके फाइब्रोस्ड होके आंख को बाहर की तरफ खींच लेगी. Yes, now as a clinician, I want to know whether the eyeball is pointing outwards, it is due to paralysis of medial rectus or it is due to fibrosis of lateral rectus. तो मैं क्या करूंगा? I will simply take the forceps, एक forceps लूंगा, तो आंख को limbus वाली साइड से पकड़ूंगा. What is limbus? Limbus is the point where there is sclera and cornea. They are attached. So sclerocorneal junction is the limbus. So I am going to hold the eyeball from the limbal side and try to rotate it inwards. अगर आंख बाहर को है तो मैं आंख को अंदर वाली साइड रोटेट करने की कोशिश करूंगा as seen in the image. If I am able to rotate the eyeball inside, it will actually tell me that it was due to paralysis of medial rectus. If I am not able to forcefully rotate it inside, that means something is holding the eyeball from the lateral side, and that is because of the fibrosis of lateral rectus muscle. So if there is movement on forceful duction, you call it as paralytic squint. If there is no movement, you call it as restrictive squint. I hope it is very much understandable. So that is why I told you that forced duction test is used to differentiate between the movement which is due to paralysis or either due to restriction. समझ में आया? All right, चलो अब हम next image पे focus. I hope guys you are very well understanding what I am trying to explain to you. Yes, please give me thumbs up if you are able to understand. Yes, quick, everybody, yes, I want your equal participation. Yes, सिर्फ देखना नहीं है, participate करना है ना? Okay, now coming over to the first. In the first image, what I'm trying to do, I'm asking the patient to look towards the ceiling. मैं क्या कर रहा हूँ, मैं patient को ceiling की तरफ देखने को बोल रहा हूँ, है ना? Okay, so on asking the patient to look towards the ceiling, I am actually looking for relative position of the eyeball, and that is your qualitative test to check for exophthalmos. Exophthalmos means protrusion of the eyeball. Yes, and this test is known as your worm's eye view test. अगर मैं सामने से पेशेंट को ऊपर देखने को बोल रहा हूं, बट if I am standing at the back side of the patient, like in second image, and I am asking the patient to look towards the ceiling, that is your Naff-Ziegler test. And both these tests are used for the assessment, qualitative assessment of your proptosis or exophthalmos. It is one and the same thing. I hope it is well understood. समझ में आया? So the use is qualitative assessment of proptosis. I hope now you will be able to see. Yes, video pause करके एक बार पढ़ लेना. Okay, चलो. Next is, okay, now this is the real patient video that I am going to show to you guys. It is very important to understand everything in a clinical way. Now let's see what's happening. देखेंगे क्या हो रहा है यहाँ पे. Asking the patient to look towards the ceiling. Now wait, yeah, wait, yep, okay, asking the patient. Now I am at the same level. Now check me and check the patient. So I am at the same level, so I am looking for relative position of the eyeball. You call it as which test? Naff-Ziegler or worm's eye test? From the front now it is worm's eye view test, and if I stand at the back you call it as Naff-Ziegler test. I hope it is clear. All right, now your PYQ, I had told you in the beginning, we will be discussing images, we will be discussing PYTs, we will be discussing PYQs, and we will also be touching a little bit of single liner questions. Okay, now most common unilateral cause of proptosis in adults, it is thyroid eye disease, but buy one get three free. So here I am going to compile the remaining 3 MCQs that have been asked before. Now since we talked about unilateral cause of proptosis, can you tell me which is the bilateral cause of proptosis in adults? It is also thyroid eye disease. Now can you tell me which is the unilateral cause of proptosis in children? It is orbital cellulitis. Now can you also tell me which is the bilateral cause of proptosis in children? It is neuroblastoma. I hope you have understood. Yes. All right. Okay. Now this question has been asked in your INI CT exam, FMGE exam, NEET PG exam multiple times. What is the definition of blindness? And whenever I say definition of blindness, there are 2 definitions. One is as per WHO, another is as per NPCB-VI. NPCB-VI means National Program for Control of Blindness and Visual Impairments. So what is the difference? So the difference is, as per WHO, if the visual acuity is less than 3/60 or visual field less than 10 degree in the better eye with best possible correction, that is as per WHO, boys and girls. But what about as per NPCB and VI? As per NPCB and VI is visual acuity less than 3/60 same, in the better eye same, but it is the presenting visual acuity, not with best possible correction. Now you say, sir, what is the difference between best possible correction and presenting visual acuity? Best possible means I'll try to improve the vision by giving glasses. But presenting visual acuity, I'll just ask the patient to sit, cover one eye and start reading from top to bottom, the Snellen's chart, right? I'm not going to give any glasses. So that is your presenting visual acuity. I hope now you have understood. Please remember, apart from these 2 definitions, there is no third definition. Don't get confused here and there. This is your gold standard criteria which I am giving, right? It has been repeated multiple times. There are high chances it may even get repeated time and again. So I don't want you to commit this mistake in your upcoming FMG exam in case it gets repeated. Now Your again PYQ, what is the criteria of social blindness? So social blindness, if the vision of the patient is 3/60 to 1/60. 3/60 means that the patient is standing at 3 meters and reading the topmost letter on the Snellen's chart, which a normal person can read after standing at 60 meters. And 1/60 is if the patient is standing at a distance of 1 meter and reading the topmost letter on the Snellen's chart, while a normal person can read from a distance of 60 meters. Okay, so visual acuity 3/60 to 1/60. Now, can you tell me the most common cause of blindness or preventable blindness in adults? Yes, anyone? Anyone? Yes, can you tell me? It is your cataract. Okay, can you tell me the most common cause of blindness in children? Vitamin A deficiency. Okay, can you tell me the second most common cause of blindness in adults? First is cataract, second is glaucoma, third is ARMD, fourth is trachoma, fifth is onchocerciasis. Onchocerciasis. I hope it is clear. All right. Okay, let's move ahead. I hope you are comfortable with the speed and also with the content. So every slide consists of at least 3 to 5 concepts. All right, children, I have already told you it is vitamin A deficiency. Yes, very good, Dr. Medicomancy. Wonderful. Okay, now a 15-year-old boy is brought for a routine eye checkup. Mind you, routine eye checkup means the patient has just visited for eye examination. No complaints of loss of vision, nothing. On examination, the following is seen. What are these small dots? What is your diagnosis? So, boys and girls, it's simple. The diagnosis is your blue dot cataract. Blue dot cataract, which is the most common congenital cataract. But boys and girls, it is not associated with loss of vision. Can you tell me a congenital cataract which is associated with loss of vision? That is your lamellar or zonular cataract. But here it is blue dot cataract. So what are the clues which are given? 15 साल का बच्चा है, रूटीन आई चेकअप के लिए आया है, कोई लॉस ऑफ विजन नहीं है, बट आपने देखा छोटी छोटी डॉट्स हैं. बट यू विल से सर, इफ देयर इज कैटरेक्ट, व्हाई देयर इज नो लॉस ऑफ विजन? बिकॉज दीज dots are so small that they are not able to restrict the light rays falling on the retina. And this image that you see here, of course you see good size of blue dots, but this is under 20x, 30x or maybe 50x magnification, right? Okay, now I am going to show you one real patient video of that of blue dot cataract which are merged together. So check this out. Can you appreciate?
सामने देखो, आंख पूरी खोलिए, लाइट में देखिए, लाइट में सीधा 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 सीधा, स्ट्रेट अहेड. अब साइड में देख रहे हैं सर, सामने.
Okay, now wait, I'll just pause. Now, can you appreciate these small dots? I am seeing this under 30x magnification. And you will say, sir, why you call it as blue dot? Because when the light strikes the small opacities, the reflected light appears blue in color. It is not that these opacities are blue in color. These opacities are white only, the precipitation of insoluble proteins only. But it just appears like blue on reflection. So don't worry for that, right?
Right.
I hope it is clear.
थोड़ा सा, little bit. थोड़ा सा right.
Okay.
Very good.
So you can appreciate. So this patient did not have any complaints of loss of vision. It was only via chance discovery. So guys, I always say one thing. बहुत सारे स्टूडेंट्स अभी बोलते हैं
कि लेंस में प्रॉब्लम है ना.
देखो, बहुत सारे स्टूडेंट्स बोलते हैं कि सर एमबीबीएस तो हमारी खत्म होने वाली है, व्हाट नेक्स्ट, अभी कितने एग्जाम और क्लियर करने हैं. लेट मी टेल यू, all of you are really hard working students, right? I know you inside out. I have been in touch with so many students. I have seen my students first clearing foreign medical graduate exam, then acing NEET PG and even INI CT exam. I still remember when I was in PGI, so there was one student who had joined my department. He was FMGE student from Ukraine. The time when he got passed, then there was not that war situation, but yes, and now he has cleared his MS in ophthalmology, and now he is working in a good private hospital and doing pretty well, and he's very much satisfied. So what we see is, on Instagram, on Facebook, there is so much of negativity, right? Just by seeing one or two posts in which the patients are getting angry over doctors, we start to think that okay, we have to be strict to the patients, so हमें patient से बिल्कुल to the point बात करनी है, हमें ज़्यादा involve नहीं होना है, we have to take patients like any other consumer. No, not at all, not at all. Just by looking over to one two lone post, we cannot paint every patient with the same paintbrush. Let me tell you, patients are so thankful. Imagine the patient is coming to you with just perception of light due to mature cataract, and just after 25 to 30 minutes of surgery, the patient has become 6/6 or maybe 6/9, and the patient presents to you with so much of gratitude. I cannot express you. While talking to you right now, I am literally having goosebumps. So you are actually preparing to become the great doctor like this. You are going to treat your patients well, you are going to take the blessings of your patients, and with that you will earn respect, dignity, and a lot of wealth in the community. So that is our main aim. We have to be ethical, we have to serve the patients, and in the end, when you sleep at night, you should be super satisfied with whatever you are doing, right? So all of you have to promise me that you will not get any negative thoughts on seeing a few Instagram posts in which the patients are bashing doctors, they are screaming upon doctors. This is just 0.01%, boys and girls, just 0.01, and 99.99% of the patients, they are full of gratitude, they're full of love, full of affection. And recently, one patient who is on follow-up with me, and he is an old army veteran, and he's 80 years of age, and the moment he enters my OPD, he tries to touch my feet every time, and I, with my folded hands, request him not to do that. Do you understand that? But no one will talk about it. Everyone will talk about how the doctors are treated by few 0.01% of the patients. So you have to be full of empathy, you have to be full of your dedication, and for that you have to clear this exam. That I am sure that you are going to clear it, right? Okay, so let's move over to our next slide, and this slide consists of 6 MCQs, 6 in 1. So can you answer me? Yes, most common complication of cataract surgery. Can you tell me what is this complication, boys and girls? This is your after cataract. After cataract, it can be Elschnig pearls or Sommering ring. This is your PYQ. Cause of loss: a patient had an uneventful cataract surgery. After 2 to 3 months, the patient presented with painless loss of vision. What will you suspect? It is your Irwin gas syndrome, which is cystoid macular edema. Can you appreciate? This is the OCT of the macula, and you can see small cysts which are present at the macula. This is in the Henle's layer. Which layer? Henle's layer, outer plexiform layer. There are cysts. This is your FMG 2023 July question, right? Henle's layer, and this is cystoid macular edema, Irwin gas syndrome. Okay, now there is next complication of cataract surgeries. There is red eye with keratic precipitates, with cells in the anterior chamber, hypopyonis, pus in the anterior chamber, periorbital edema, and there is loss of vision which is associated with pain. What will you suspect? This is, boys and girls, your endophthalmitis. Okay, now if the endophthalmitis is happening within 6 weeks of surgery, operation करने के 6 हफ्ते में अगर patient को endophthalmitis हो रहा है, the most common organism, your PYQ, is Staph epidermidis. If this is not in the option, go for Staph aureus. But if it is happening after 6 weeks of surgery, the organism is Propion bacterium acnes. This is also your PYQ. How will you prevent it? इसको कैसे prevent करेंगे? तो आपने अक्सर देखा होगा, whenever we perform cataract surgery, we always drape the eyelid, eyelashes with 5% povidone iodine. 5% povidone iodine is very affected in neutralizing staph epidermidis, staph aureus, propionibacterium acnes, right? So these are your 6 MCQs which were asked out of just based on this slide. 3 MCQs were there. First was Irwin gas syndrome, second was which is the most common organism, third was how to prevent it. Just back to back 3 MCQs in the same July 2025 session. Okay, July 2023 session. Okay, now coming over to a 25-year-old male comes with these diagnosis. Please let's first identify what is this. Can you appreciate? These are cells in the anterior chamber. Now what are these? Can you appreciate? A triangular form which is there at the back of the cornea. What is this? These are your KPs. KPs means keratic precipitates. Now you know that there are cells in the anterior chamber. There are keratic precipitates in the anterior chamber. Patient is young. So what is your diagnosis? What do you feel? This is your anterior uveitis. But what is the most common cause of anterior uveitis? It is idiopathic. So what will be the treatment of choice? Topical steroids. Anterior uveitis treatment of choice will be topical steroids. But what is the most common complication of anterior uveitis? It will be secondary glaucoma. Okay, but if the uveitis is happening time and again, so most common complication in recurrent anterior uveitis, it will be secondary cataract. I hope you have understood. So glaucoma is the most common overall complication of anterior uveitis. But if we are talking of recurrent disease, so then it will be your cataract. Now this was the question which was asked. So one, you can see there is anterior uveitis. Second, you can see that there is angle closure glaucoma. How will you differentiate between anterior uveitis and angle closure glaucoma? Just on the basis of one point you can tell me, because all other symptoms are overlying, right? So just on the basis of one point you can actually tell me what is the diagnosis. Check out the pupil. So pupil of the anterior uveitis is constricted, non-reacting, irregular, while the pupil of the angle closure glaucoma is mid-dilated, non-reacting. I hope you have understood. Now you can appreciate. Can you see? Non-reacting, mid-dilated and oval pupil. Okay, so based on this, whatever history is there, if anything about the pupil is mentioned and you are getting confused between the anterior uveitis and angle closure glaucoma, just on the basis of the configuration of pupil, you can actually lead to the diagnosis. You can try doing it while solving MCQs, and 100% of the times you will get this question correct. Okay, all right. चलिए आगे चलते हैं. अब देखो, मैंने आपको बताया the cells in the anterior chamber. Now this video which I am going to present to you, it is a small 20-25 second video, but it took me 45 minutes to create this video for you. Why? Because I want to tell you what is the earliest diagnostic feature of anterior uveitis. अर्लीस्ट डायग्नोस्टिक फीचर एंटीरियर यूवीआइटिस का क्या है? वो है जो आपको यहां पे दिखेगा. एक बार दिख गया तो आप कभी भी भूल नहीं पाओगे. लेट्स सी क्या दिख रहा है आपको. देखेंगे ध्यान से देखेंगे. कैन यू अप्रिशिएट समथिंग इन द एंटीरियर चैम्बर विच इज रोटेटिंग लाइक एनीथिंग? ध्यान से देखो,
बीच में रख लो बस. हाँ, बहुत बढ़िया.
ध्यान से. I'm sure you will remember it for the rest of your life. That's my promise. Let me increase some magnification. You will see. Now, can you appreciate something? Can you appreciate these small dots? What are these? Boys and girls, these are cells in the anterior chamber. So, now what is your diagnosis? This is your anterior uveitis. So can you tell me the earliest diagnostic sign that you see in anterior uveitis? It is cells in the anterior chamber. क्यों बता रहा हूं मैं? क्योंकि एक ऑप्शन आपकी होती है cells in the anterior chamber, दूसरी आपकी होती है proteins in the anterior chamber. लेकिन आप ज्ञानजीवी लोग proteins in the anterior chamber मार्क करके आ जाते हैं. लेकिन अब आपने देख लिए दैट देयर आर सेल्स इन द इंटीरियर चैम्बर, यू कैन नॉट सी प्रोटीन्स इन द इंटीरियर चैम्बर, तो आपको पता लग जाएगा अरे सर ने वो स्पेशल सेशन में एक वीडियो दिखाई थी जिसमें वी कुड अप्रिशिएट द सेल्स फ्लोटिंग इनसाइड द इंटीरियर चैम्बर, सो देयर वर नो प्रोटीन्स, सो इट हैज टू बी सेल्स इन द इंटीरियर चैम्बर. दिस इज हाउ यू कनेक्ट द डॉट्स ड्यूरिंग योर एग्जाम. सो इट इज द अर्लीस्ट डायग्नोस्टिक फीचर ऑफ एंटीरियर यूवीआइटिस. ओके, चलिए नाउ दिस इज योर PYQ in acute anterior uveitis pupil is, अभी तो हमने ये करा है, ओवल न, इट इज सीन इन एंगल क्लोजर ग्लॉकोमा, सर्कुलर नहीं रे, ये तो नॉर्मल में होता है, डायलेटेड नहीं रे, मिड डायलेटेड ओवल तो एंगल क्लोजर ग्लॉकोमा में होता है, स्मॉल एंड इरेगुलर. व्हाई स्मॉल एंड इरेगुलर? बिकॉज ऑफ पोस्टीरियर साइनिकी. दिस इज योर आंसर. आई होप इट इज क्लियर. ओके, चलिए आगे. नाउ 4 more MCQs coming up, boys and girls. Now there is a fundus image in which you can see snowball opacities and snow banking. So what is this? Can you tell me? So this is your intermediate uveitis. So snow banking and snowball opacities is a diagnostic feature of intermediate uveitis. समझ में आया? Okay. पिज्जा पाई रेटिनोपैथी देख पा रहे हो, इसको हम सॉस एंड चीज रेटिनोपैथी भी बोलते हैं. इट इज सीन इन विच कंडीशन? इट इज सीन इन CMV retinitis. Fundus based image was asked. Okay, all right. Now candle wax drippings. Candle wax drippings are seen in sarcoidosis. Headlight in fog appearance. It is seen in toxoplasmosis. 4 MCQs in one slide. Smash. All right. Okay. Now 3 simple स्पॉट डायग्नोसिस. कैन यू टेल मी? मेरे को स्पॉट डायग्नोसिस बताइए. कुछ हमने डिस्कस कर लिए हैं, इसमें हम इस पे फोकस करेंगे पहले. क्या लग रहा है ये? अभी तो हमने बात करी. दिस इज योर विच पिज्जा? डोमिनोज पिज्जा. विच अपीयरेंस? पिज्जा पाई अपीयरेंस. बट योर FMG क्वेश्चन वाज what is the treatment of this disease? So first and foremost you were supposed to know the diagnosis. You were not supposed to answer the diagnosis. You were supposed to think of the diagnosis, and based on that you were supposed to mark the right drug. So the treatment is ganciclovir. Treatment is ganciclovir. So first is pizza pie appearance, which we have already done. Second is CMV retinitis, and third is ganciclovir, which is your PYQ. It is your drug of choice, boys and girls. Very, very good. Wonderful, wonderful. Very good, wonderful. All right. Okay. Dr. Kadri, thank you very much. All right. Now, a 5-month-old child is brought by parents to IOPD with following presentation. अब ध्यान से देखिए, यहाँ पे सिर्फ एक स्मॉल हिस्ट्री दी गई है और साथ में कंडीशन दी गई है. क्या लग रहा है ये देख के? What is this? This is your ground glass appearance. And can you also appreciate the big size of the eyeball? Are you able to connect the dots? कर पा रहे हैं डॉट्स को कनेक्ट? Yes. Are you able to connect the dots? Can you also appreciate that there is some tears in the Descemet's membrane? देख पा रहे हैं? This is your Habs stripe, tears in the Descemet's membrane. Now, what is that? Yes, very good, Dr. Rajvardhan Singh ji. कमाल कर दिया तुसी. Now, the answer is congenital glaucoma. Because in congenital glaucoma, there is buophthalmos, big eyes, bull-like eyes. There is ground glass appearance of the cornea. There is presence of Habs stripe. But there is one triad which is associated with congenital glaucoma. And that is your watering, which is earliest, lacrimation. Then there is photophobia. And then there is blepharospasm. But the question was in your FMG, which is the earliest sign that you see in congenital glaucoma. And can you tell me the distance, the difference between the sign and the symptom? Sign is what the doctor sees. Symptom is what the patient comes to you with. So earliest sign which the doctor sees is lacrimation. I hope it is clear. Okay. Other clinical features. Buophthalmos, I have told you. Ground glass cornea, I have told you. Habs stripe, tears in the Descemet's membrane. Now, but let's see about this patient. This patient had come to me when I was in PGI, and you can appreciate the big eyes. You call it as buophthalmos.
थोड़ा सज्जे राइट राइट, लेफ्ट लेफ्ट देखो। काले मोतिया की दिक्कत कब से है?
बचपन से।
बचपन से। सो आई आस्क्ड कब से है? शी सेड बचपन से। दैट मींस congenital glaucoma. I hope it is understandable and you can appreciate ophthalmos. Very important. Sometimes they would just give you an image with very enlarged eyeball and then we'll ask you the diagnosis. The diagnosis is going to be simple, ophthalmos. All right. चलिए अब हम आते हैं मैनेजमेंट ऑफ ग्लोकोमा की तरफ। इस स्लाइड में भी आपको 4 इंपॉर्टेंट एमसीक्यूज मिल जाएंगे जो कि आपके PYQs हैं। ओके, नाउ प्लीज सी टू इट। एक बार देखेंगे, ध्यान से देखते हैं। ये देखो, मैनेजमेंट ऑफ प्राइमरी एंगल क्लोजर ग्लोकोमा एंड एक्यूट स्टेज ऑफ एंगल क्लोजर ग्लोकोमा। पहले मैं आपको इसका मतलब समझाऊंगा। देखो, समझते हैं। प्राइमरी एंगल क्लोजर ग्लोकोमा इज दैट द एंगल इज नैरो विच इज लीडिंग टू रेज्ड इंट्राऑक्यूलर प्रेशर। रेज्ड इंट्राऑक्यूलर प्रेशर, द नॉर्मल इज 10 to 21 मिलीमीटर ऑफ मर्क्यूरी। अब रेज्ड 23 भी हो सकता है, 25 भी हो सकता है, 30 भी हो सकता है, 32, जितना भी हो, normal due to narrowing of the angle of anterior chamber. That is your primary angle closure glaucoma. Simple and straight, fair and square. But what is acute attack of primary angle closure glaucoma? Acute attack is when suddenly this angle which was narrow, ये बंद हो जाता है अपने आप, due to which अब तो पानी का बाहर जाने का रास्ता ही नहीं है, means aqueous humor cannot go out of the anterior chamber anyhow. It will start building up the pressure inside the eyeball and the pressure will rise from 20-21 millimeter of mercury to 60-65 70 millimeter of mercury in just 30 minutes, boys and girls. That is your acute attack of angle closure glaucoma. दोनों का ट्रीटमेंट अलग रहेगा। मेरे पास एक पेशेंट आया, मैं अपनी OPD में बैठा हूं, पेशेंट का प्रेशर रेज्ड है, मैंने देखा एंगल नैरो है, तो मैं क्या करूंगा, मैं उसको ड्रग ऑफ चॉइस दूंगा विच इज योर प्रोस्टाग्लैंडिन एनालॉग्स। सो द ड्रग ऑफ चॉइस फॉर प्राइमरी एंगल क्लोजर ग्लोकोमा, फॉर प्राइमरी ओपन एंगल ग्लोकोमा एंड फॉर नॉर्मोटेंसिव ग्लोकोमा, इट इज प्रोस्टाग्लैंडिन एनालॉग्स, लेटेनोप्रोस्ट, ट्रेवोप्रोस्ट, बिमेटोप्रोस्ट, टेफ्लूप्रोस्ट। समझ में आ गया? बट if the patient comes to me with acute raised intraocular pressure 60-70 के साथ आया है, तो तब मैं ये दवाइयां तो नहीं दूंगा, ये तो धीरे धीरे प्रेशर को नीचे लाएंगी। अब ये तो मेडिकल इमरजेंसी होगी क्योंकि पेशेंट को एक्यूट अटैक आ गया है, प्रेशर जो है 60-65 पे नाच रहा है जाके। तो अब मैं क्या करूंगा, अब मैं प्रेशर को सडनली नीचे लाने की कोशिश करूंगा। वो मैं कैसे लाऊंगा, तो उसमें मैं वो ड्रग दूंगा जो कि इमीडिएटली अटैक करेगी प्रेशर के ऊपर, इमीडिएटली प्रेशर को नीचे लेकर आएगी, एंड दैट ड्रग इज इंट्रावेनस मैनिटॉल विच स्टार्ट्स इट्स एक्शन in as less as 20 minutes, boys and girls. This is your NEET PG 2024 क्वेश्चन, पिछले साल NEET PG में पूछा गया था। और इसके साथ ये जो एंगल जो क्लोज हो गया, इसको मैं खोलने की कोशिश करूंगा। कैसे? पाइलोकार्पिन देके। पाइलोकार्पिन इज गोइंग टू कॉन्स्ट्रिक्ट द प्यूपिल विच में ओपन द क्लोज्ड द कंप्लीटली ब्लॉक्ड एंगल ऑफ एंटीरियर चैम्बर। सो यहां पे यही लिखा हुआ है, पाइलोकार्पिन टू रिलीव द ब्लॉक and intravenous mannitol to decrease the intraocular pressure. That is the difference between acute attack of angle closure glaucoma and primary angle closure glaucoma. Okay, now once the pressure has come down, what I am going to do next? I am going to perform a laser iridotomy. लेजर आइरिडोटमी से मैं आइरिस में एक छेद कर दूंगा, आप ये देख पा रहे हो। इससे एक एक्स्ट्रा विंडो मिल जाएगी एक्वस ह्यूमर को पोस्टीरियर चैम्बर से एंटीरियर चैम्बर में आने की इजीली। सो इट विल नॉट फर्दर लीड टू अगेन कंप्लीटली ब्लॉकिंग ऑफ द एंगल ऑफ एंटीरियर चैम्बर। इज इट अंडरस्टैंडेबल? और मैं एक आंख में नहीं करूंगा, मैं दोनों आंखों में करूंगा। इफ वन आई इज प्री डिस्पोज्ड, एक आंख में अगर हो चुका है तो देयर आर हाई चांसेस दूसरी आंख में भी कभी भी हो सकता है, तो दूसरी आंख में मैं प्रोफाइलैक्टिक लेजर आइरिडोटमी कर दूंगा। ठीक है, जैसे आप यहां देख रहे हो, पहले एंगल नैरो है, यस, और यहां पे बिल्कुल एंगल ब्लॉक हो गया, कंप्लीटली ब्लॉक। सो द प्रेशर विल बी 60-65 इन जस्ट 30 मिनट्स। दैट इज योर मेडिकल इमरजेंसी। आई होप इट इज क्लियर, बॉयज एंड गर्ल्स। समझ में आ रहा है? प्लीज कंफर्म मी वंस। समझ पा रहे हो? द आइडिया इज that you should be able to understand. This is what we are going to do in upcoming face-to-face sessions. We will make sure कि हर चीज आप अच्छे से समझे. We are starting the face-to-face sessions from 10th of December, and I have already told you which faculty lineup is there. So it will be our effort to help you revise everything which you have done so far. हमारा effort रहेगा कि क्योंकि आपका एग्जाम अभी 17 जनवरी को है, तो ये 7-8 दिन आपके हम लेकर उसमें हम आपको अच्छे से ओवरऑल रिवाइज करवा दें सारा, सो दैट यू आर एबल टू पास द एफएमजी एग्जाम इजिली, है ना. ये हमारा एफर्ट रहेगा. ओके, चलिए आगे. नाउ कमिंग ओवर टू एंटी ग्लोकोमा ड्रग्स. दिस इज अगेन योर प्रीवियस ईयर क्वेश्चन. विच इज द ड्रग विच इज कॉन्ट्रा इंडिकेटेड इन एस्थमा? बता पाएंगे? It is beta blocker. Which beta blocker? Non-selective beta blocker. That is your timolol. समझ आया? Okay. Now a drug which is contraindicated in neonates, which is contraindicated in patients which have a history of depression, but it is drug of choice in pregnancy. That is your brimonidine, category B drug. Now one drug which causes iris hyperpigmentation, one drug which causes increased size of eyelashes, that is your latanoprost, which means prostaglandin analogs. But one drug which is contraindicated in aphakics. What is aphakia? Aphakia is a condition in which there is absence of crystalline lens, and that is your dipivefrin, because it causes cystoid macular edema. समझ आया? तो ये 4 ड्रग्स हैं जो कि आपकी एफएमजी में पूछी जा चुकी है. टीमोलॉल तो कई बार पूछा जा चुका है, ब्रिमोनिडीन एक बार पूछा गया है, आइरिस हाइपरपिगमेंटेशन ट्राइकोमेगैली एक बार पूछा गया, सीएमई 2 बार पूछा गया है. तो ये आपको पता होना चाहिए. और कहां पे पढ़ा अभी हमने सीएमई? बता पाएंगे कहां पढ़ा? इन द कॉम्प्लिकेशंस ऑफ कैटरेक्ट सर्जरी. विच कैटरेक्ट सर्जरी? इरविन गैस सिंड्रोम, इन विच देयर इज cyst like swelling of the outer plexiform layer of the retina, and it happens 2 to 3 months after cataract surgery. समझ में आया? Okay, yes. चलो, I hope you are not tired. तो nearly 50% of our job is done. Next, there are just 10-12 more slides and then we are done. So I hope you are just chilling and relaxing and revising ophthalmology quickly with me. Yes? All right. चलिए आगे. Now, next patient please. A 65-year-old patient with high myopia, risk factor, sudden painless loss of vision, flashes of light means photopsia, curtain falling sign keyword has been asked multiple times. That is why I have written this sign in bold letters. Then comes to IOPD. What is the diagnosis? Can you appreciate this? ये देख पा रहे हैं? What is this? This is your horseshoe shape. This is your horseshoe shaped retina. ठीक है जी? Horseshoe shaped retina is there and it is more commonly on the superior-temporal side, and typically this is rhegmatogenous retinal detachment. Rhegmatogenous retinal detachment, what is the treatment? It is pneumoretinopexy. Pneumoretinopexy is you inject an air bubble, it will rise up. It will push back the detached part of the retina, or you can also go on for scleral bending or silicon bending. I hope it is clear. All right, I hope it is clear. Okay, now coming over to most important prognostic factor in diabetic retinopathy. Which is the most important prognostic factor? Most important prognostic factor in diabetic retinopathy is your duration, not the control. Duration means if there is one patient who is having diabetes from past 10 years but his sugar levels are controlled, but there is another patient who is having diabetes from past 5 years but the sugar levels are not controlled, the patient who is having diabetes from last 10 years will have high chances to develop diabetic retinopathy. That is why duration is more important risk factor. समझ में आया? Okay. Now next is, when do you go on for fundus examination? If there is type 1 diabetes, the fundus examination may be postponed till 5 years of diagnosis. तो जब आज अगर diagnosis हुआ है तो 5 साल के बाद हम फंडस एग्जामिनेशन करेंगे, बिकॉज इट यूजुअली टेक्स 5 years फॉर द डेवलपमेंट ऑफ रेटिनोपैथिक चेंजेस. समझ में आया? बट In non-insulin dependent diabetic mellitus, type 2 diabetic mellitus, you will go on for immediate fundus examination. Why? Because type 2 diabetic mellitus or non-insulin dependent diabetic mellitus is asymptomatic. If you are diagnosed with type 2 diabetic mellitus today, you don't know whether you are having this since yesterday or since last 10 years, because this is asymptomatic. So you will go on for immediate fundus examination, and it will be helpful for the doctor in knowing whether this is less than 5-year-old or more than 5-year-old. In case there are retinopathic changes, so you can be assured that this happened like more than 5 years back, but diagnosed today. If there are no fundus changes, you can be assured that this diabetes happened within last 5 years, because I told you it takes minimum 5 years for the development of retinopathic changes. I hope it is clear. Okay, all right. Now another 4 MCQs coming up your way, boys and girls. Earliest feature of diabetic retinopathy, it is your microaneurysm. Hallmark of proliferative diabetic retinopathy. Hallmark, proliferation. Proliferation means there is proliferation of vessels, that is neovascularization. Can you tell me what is the cause of loss of vision in diabetic retinopathy? Some would say, sir, dot hemorrhages. Some would say, sir, neovascularization. Some would say, sir, retinal detachment. No, it is actually cystoid macular edema. Yes, and there was one recent MCQ which was asked in last FMG exam, that a patient has come to you with loss of fundus glow. Loss of fundus glow mean when you shine the direct ophthalmoscope from a distance, there is no red reflex. Red reflex is when the light enters the eye and it gets reflected back from the retina. You must have seen while taking the photographs with the camera flash, you see red eye. What is red eye? Red eye is nothing but the reflection of the light from the retina. समझ में आया है ना? So red reflex is that reflex which is captured by the camera with a flash. But if there is vitreous hemorrhage, hazy media, the red reflex cannot be perceived. So absence red reflex can be seen in vitreous hemorrhage, retinal detachment. समझ पा रहे हैं? So the answer to that question, that FMG question, was vitreous hemorrhage, in which there is loss of red reflex. Okay, chalo, coming on to next case scenario. A 48-year-old hypertensive female on OCPs, oral contraceptive pills, comes to IOP with sudden painless loss of vision. What can be the diagnosis? Can you see the image? This image has been asked multiple times. This is your typical splash tomato appearance, and you can appreciate that there is cystoid macular edema and there are multiple hemorrhages. So this is a single straightforward case of central retinal vein occlusion. Don't confuse CRVO with CRAO. In central retinal artery occlusion, the fundus will be pale and milky white. Here it is splash tomato. What is splash tomato? You take the tomato, throw it on the wall. After striking the wall, it will leave some spotting. The similar picture is that of the retina or fundus. Okay, all right. This is CRVO, my dear Dr. Mansi. It is CRVO, है ना? Okay. All right. Splash tomato appearance, CME, disc edema, and it can also lead to 100-day glaucoma. What is the diagnosis? We have just discussed CRVO. Pale milky white retina, boxcar appearance of vessels, cherry red spot on the macula, CRAO. And can you appreciate a typical smokestack appearance which is seen on FFA, fundus fluorescein angiography, smokestack appearance? This is the diagnostic feature seen in which disease? बता पाएंगे? Yes, please. बता पाएंगे? बताइए. I am waiting for you guys. It is your, हाँ जी, किसमें होगा ये? 15 से 20% पेशेंट्स में दिखता है ये. बताएंगे? बताऊं? Okay, it is seen in central serous retinopathy, CSR. CSR. All right. चलते हैं आगे. Now, coming over to our next patient, 18-month-old child with white pupillary reflex. देख पा रहे हैं? White pupillary reflex को क्या बोलते हैं? We call it as leukocoria and exotropia in right eye. On CT scan, there is a calcification. This calcification thing has been asked multiple times in your FMG exam, and sometimes they would also add one line, that is on histopathology there is flexor Wintersteiner rosettes, and you have to think on single ground that we are talking of one specific tumor of the retina in which there is calcification in boys and girls, that is your retinoblastoma. But if you will appreciate this CT scan image, you will see that there is this tumor having calcification, this tumor having calcification, and there is this tumor which is also visible in the CT scan. So it is forming a triangle. You call it as trilateral retinoblastoma, which is bilateral retinoblastoma and pinealoblastoma, tumor of pineal body, pinealoblastoma. What is the treatment? There is a VEC regimen, that is vincristine, etoposide and cisplatin. If cisplatin is not in the option, go for carboplatin. Cisplatin, carboplatin दोनों भाई भाई हैं. Okay, all right, चलिए आगे. Coming over to our next case scenario. So there are multiple images which are given. तो ये क्या है, क्या देख पा रहे हैं यहाँ पे? You are able to appreciate that the margins of the optic nerve head are blurred, and you can appreciate that there are flame shaped hemorrhages. यहाँ पे if you will carefully see, you will see some flame shaped hemorrhages. Here also you will see peripapillary hemorrhages. देख पा रहे हैं ना? And on perimetric chart you will see that there is enlargement of blind spot. What is your diagnosis? This question was asked in your last year NEET PG 2024 exam morning session. Last year NEET PG happened in 2 sessions, morning session, evening session, but since the exam taking body is same, NEET PG as well as FMG, so I am discussing some tricky questions asked in NEET PG as well, so that if it gets repeated you should be able to mark it correctly. So we are talking of which disease? Papilledema. Okay, I hope it is clear. All right, now coming over to the topic of squint. Which diplopia is this, crossed or uncrossed? ध्यान से देखेंगे तो यहाँ पे false image is seen onto the same side. So this is your uncrossed diplopia. Remember, in esotropia there will be uncrossed diplopia, and in exotropia there will be crossed diplopia. So you can appreciate there is left eye esotropia, so false image is on the same side, so that is why it is uncrossed diplopia. So uncrossed means that the false image is not crossing the true image, the actual image. So actual image is this, false image is on the same side, so that is why it is uncrossed diplopia. All right, next is which nerve palsy would cause this? Can you see? Down and out position. This is your recent INI CT exam question. 2 years back it was asked in your FMG exam as well. So the position of the eyeball is down and out, and you will also see that the pupil is relatively more dilated as compared to the other eye. This is your third cranial nerve palsy, third cranial nerve palsy. And can you also tell me which muscle would cause dextro elevation? See, dextro elevation, this is the position which is shown in the image now. Please remember one thing, that if the eyeball is abducted, abducted means जब आंख बाहर को होगी ना, तो elevation will be caused by superior rectus, depression will be caused by inferior rectus. जब आंख अंदर को होगी, right eye की बात कर रहा हूं, तो elevation will be caused by inferior oblique and depression will be caused by superior oblique. इतना समझ में आया? अब जल्दी से मुझे बता दो, ये जो पोजीशन है ये कौन सी मसल के थ्रू है? देखो आंख एबडक्टेड है ना, बाहर को है ना, तो बाहर का मैंने क्या बोला? एलिवेशन इज वाया सुपीरियर रेक्टस, डिप्रेशन इज वाया इंफीरियर रेक्टस. तो राइट सुपीरियर रेक्टस, बट लेफ्ट आई की अगर बात करूं तो आंख अंदर को है ना, तो एलिवेशन इज वाया ऑब्लिक ना. विच ऑब्लिक? इंफीरियर ऑब्लिक, सुपीरियर ऑब्लिक. उल्टा होता है, एलिवेशन इज वाया इंफीरियर ऑब्लिक एंड डिप्रेशन इज वाया superior oblique. समझ में आया? This was the question which was asked in 2023 FMG June session exam. So I have specifically put up this question because such questions can be make or break. Even one MCQ has the ability to shift your post result party destination from Malaysia to Mahabaleshwar. So हर क्वेश्चन को हम सीरियसली लेंगे बच्चों. लास्ट टाइम FMG में आपके 23 MCQs आए थे ऑफ्थेल्मोलॉजी में. तो प्लीज ऑफ्थेल्मोलॉजी एक ऐसा सब्जेक्ट है जिसको यू कैन नॉट चूज टू इग्नोर. नहीं इग्नोर कर सकते हो आप. यू कैन इग्नोर ऑफ्थेल्मोलॉजिस्ट बट यू कैन नॉट इग्नोर द सब्जेक्ट ऑफ ऑफ्थेल्मोलॉजी इफ यू वांट टू पास FMG एग्जाम विद गुड मार्क्स. से यस और नो? यस. चलो, ऑल राइट. नाउ द सेम थिंग आई एम एक्सप्लेनिंग इट हियर. देखिए, ऑन डेक्स्ट्रोवर्जन राइट लेटरल रेक्टस, लेफ्ट मीडियल रेक्टस. ऑन डेक्स्ट्रो डिप्रेशन मैंने क्या बोला, राइट आई एबडक्टेड है ना, एबडक्टेड में जब नीचे जाएगी तो इंफीरियर रेक्टस, ऊपर जाएगी तो सुपीरियर रेक्टस. लेफ्ट आई एडक्टेड है ना, नीचे जाएगी तो सुपीरियर ऑब्लिक, ऊपर जाएगी तो इंफीरियर ऑब्लिक. तो ये देखो, ये है डेक्स्ट्रो डिप्रेशन, तो राइट इंफीरियर रेक्टस, लेफ्ट सुपीरियर ऑब्लिक. सिमिलरली अगर हम इसकी बात करेंगे तो लीवो एलिवेशन, लीवो मींस लेफ्ट, एलिवेशन, तो लेफ्ट सुपीरियर रेक्टस, राइट इंफीरियर ऑब्लिक. समझ में आ गया? ओएस मींस लेफ्ट एंड ओडी मींस राइट. ऑल राइट. और यही अगर हम लीवो डिप्रेशन की बात करें तो सिमिलरली लेफ्ट इंफीरियर रेक्टस, राइट सुपीरियर ऑब्लिक. आई होप इट इज क्लियर. चलते हैं आगे. इतना समझ में आ गया ना? ये जरूरी है आपके लिए समझ पाना, वरना गलती करने की गुंजाइश बनी रहेगी. ओके, now coming over to the topic of cornea. So quickly in another 5-10 minutes we are winding up the session. और उसके बाद please and please मुझे जरूर feedback देना. How did you like the session? I always ask my students to give your feedback. It motivates us to put even more better efforts next time. It gives us energy to keep working hard with you guys. हम यहाँ पे सिर्फ आपसे हार्ड वर्क नहीं करवाते, हम खुद भी आपके जितना हार्ड वर्क करते हैं. हम इकट्ठे मिलके एफएमजी को क्रैक करेंगे. आप नहीं क्रैक करोगे, हम इकट्ठे मिलके क्रैक करेंगे, है ना? इट इज अवर रिस्पॉन्सिबिलिटी टू होल्ड योर हैंड एंड हेल्प यू क्लियर एफएमजी एग्जाम. और उसके बाद जो आगे का नीट पीजी एग्जाम होगा उसमें भी हम आपकी हेल्प करेंगे. डोंट वरी फॉर दैट. ओके, नाउ नेक्स्ट इज a 30-year-old male has a history of prolonged contact lens wear. Contact lens की प्रॉब्लम है ना? And he develops redness, but उसने इग्नोर कर दिया. Then later after a month he visits IOPD with this condition of the cornea. अब यहाँ पे सीधा उन्होंने पूछा, एक पेशेंट है भाई, कॉन्टेक्ट लेंस वो डाल रहा है, उसको रेडनेस हुई, उसके बाद इसके साथ आया, दैट मीन्स कॉर्नियल अल्सर के साथ आया. तो आप बता सकते हो द मोस्ट कॉमन ऑर्गेनिज्म कॉजिंग contact lens associated corneal ulcer, that is your pseudomonas. Bacterial corneal ulcer है, but the organism is pseudomonas. What are the complications? तो यहाँ पे आप बीच में shiny bulge देख रहे हो. This is your desmetocele, when there is shiny bulge at the center of the white opacity. And if the patient coughs if the patient sneezes achoo due to sudden raised pressure, this desmetocele can get ruptured and lead to perforation of the corneal ulcer. Done? Okay, so these are possible complications. Why I am telling you? Because it was asked what is the definition of desmetocele. Desmet's membrane is one of the layer of the cornea. Because of the sloughing of the superficial layers and normal intraocular pressure, there is bulging of the Desmet's membrane. So Desmet's bulging is desmetocele. Cele means swelling, है ना? Cele, it appears to be like small cystic swelling. Desmet's seal. All right. Now a 50-year-old farmer visits IOPD with history of injury by a cow's tail while milking the cow. So cow tail injury, या फिर organic matter injury, या a leaf touching the eye. So it points towards a single type of keratitis. Keratitis means inflammation of the cornea or corneal ulcer, and that is your fungal keratitis. You can appreciate that the margins are non-defined, fluffy margins, typical, and you can also see that there is hypopyon, but the hypopyon is fixed in fungal keratitis. Okay, most common fungus is Aspergillus fumigatus, but there is Wesley's immune ring. What is Wesley's immune ring? It is the host antibodies against the fungal antigen which forms the small demarcation line along the keratitis. तो यहाँ पे आप देखो, यहाँ पे छोटी सी एक लाइन हो जाएगी एंटीजन एंटीबॉडी की. तो ये रिंग नहीं होता है, इट इज जस्ट द सराउंडिंग ऑफ द फंगस. तो रिंग तो एक ऐसी नाम है, डोंट थिंक ऐसे गोल कलर का रिंग होगा. सो उसको हम बोलते हैं वेस्लीज इम्यून रिंग. एंड ट्रीटमेंट, इफ यू नो द इटियोलॉजी, यू नो द ट्रीटमेंट. इफ द फंगस इज ब्रांच, यू गो ऑन फॉर नेटामाइसिन. इफ इट इज अनब्रांच, यू गो फॉर निस्टैटिन. And new generation antifungal is voriconazole. I hope it is clear. Okay, चलो आगे चलते हैं. All right. A 21-year-old with decreased vision, frequent change of myopic glasses. 21 साल का यंग पेशेंट है, विजन उसकी कम हो गई है, जो ग्लासेस हैं उसका नंबर बार बार चेंज हो रहा है. तो फॉलोइंग इमेजेस आर गिवन. बेस्ड ऑन दिस वी हैव टू टेल द डायग्नोसिस एज वेल एज वी हैव टू मैनेज द केस. तो ये क्या है, ये वर्टिकल स्ट्राइएशंस आपको दिख रही हैं जिनको बोलेंगे वॉग स्ट्राई. डोंट कंफ्यूज वॉग स्ट्राई विद दैट ऑफ हाफ स्ट्राई. हाफ स्ट्राई आर tears in the descemet membrane. Walk striate stretch in the descemet membrane. H for halves, H for horizontal. V for walked, V for vertical striations. And you can see the Munson sign. Can you appreciate the Munson sign? On asking the patient to look downwards because of the cone of the keratoconus coming behind the lower lid, the lower lid will take the V-shaped position. And what is this? Can you appreciate the येलो पॉइंटर्स? सो दिस इज योर, यहाँ पे देखो ध्यान से, आपको गोल्डन ब्राउन कलर का कुछ एक रिंग लाइक कुछ दिख रहा होगा, इसको बोलेंगे फ्लीशर रिंग. दिस इज एक्चुअली आयरन डिपोजिशन एट द कॉर्नियल एपिथेलियम. एंड लास्टली व्हाट यू सी हियर, यहाँ पे देखोगे स्मॉल ऑयल ड्रॉप समथिंग नजर आ रहा है, इसको ऑयल ड्रॉप रिफ्लेक्स बोलेंगे, विच इज सीन इन योर डिजीज एंड दैट इज योर केराटोकोनस. सो वी आर टॉकिंग ऑफ केराटोकोनस. दिस इज योर ऑयल ड्रॉप reflex. Don't confuse oil drop reflex with that of oil drop cataract. Oil drop cataract is due to galactosemia, and also don't confuse it with that of oil globule reflex. Oil globule reflex is due to lenticonus, but oil drop reflex is due to keratoconus. Okay, what will be the management? So पहली management ये होती है कि आप इसमें toric glasses दे देते हो क्योंकि astigmatism बहुत high होता है. तो toric contact lenses जो होते हैं, toric contact lenses से astigmatism थोड़ा दूर हो जाएगा, राइट. एंड जो कॉन्टेक्ट लेंस होते हैं आप देते हो रिजिड गैस परमीएबल कॉन्टेक्ट लेंसेज. दे शुड बी रिजिड बिकॉज ऑफ द रिजिडिटी इट विल पुश बैक द कोन ऑफ keratoconus. And what else? You can go on for C3R. C3R is collagen corneal cross linking with riboflavin. Lastly, you can change the cornea. आप कॉर्निया की ट्रांसप्लांटेशन कर देते हो जिनको हम बोलते हैं केरेटोप्लास्टी. ठीक है जी, ऑल राइट. नाउ रेडनेस इज देयर, वाटरिंग इज देयर, फॉरेन बॉडी सेंसेशन इज देयर, फोटोफोबिया, प्री ऑरिकुलर लिम्फोडिनोपैथी. आंख का क्या कलर लग रहा है? पिंक. क्या बोलेंगे? पिंक आई. व्हाट इज द अदर नेम ऑफ पिंक आई? एपिडेमिक keratoconjunctivitis. The most common organism causing epidemic keratoconjunctivitis is adenovirus. But other eye आप देखोगे इसमें क्या लग रहा है? सब कंजंक्टिवल हेमरेज लग रही है. ठीक है, सब कंजंक्टिवल हेमरेज इज सीन विद विच मोस्ट कॉमन वायरस? It is a group of virus which is pico-RNA. Pico-RNA, pico-RNA के अंडर दो वायरस होते हैं, Coxsackie A24 and Enterovirus 70. Okay, so most common is Enterovirus 70. देखेंगे यहाँ पे लिखा हुआ है acute hemorrhagic conjunctivitis, most common is Enterovirus 70. While eye flu, pink eye, epidemic keratoconjunctivitis, it is adenovirus. But cornea is involved, yes or no? Yes, in both of the conditions. If not controlled, cornea may be involved, hence the name keratoconjunctivitis. So yes, cornea is involved, may be involved. Okay, now a newborn age 7 days, following features are seen. तो just 7 दिन की उम्र में following हर्बर्ट पिट्स आ गए. ट्रिकियासिस. अच्छा, व्हाट इज ट्रिकियासिस? ट्रिकियासिस इज मिसडायरेक्टेड आई लैशेस. देख रहे हो ना, मिसडायरेक्टेड मतलब नॉर्मल आई लैश की डायरेक्शन कैसे होती है? बाहर को एंड ऊपर, अपर आईलिड की, लेकिन ये तो अंदर को है, तो दैट इज ट्रिकियासिस. अच्छा, व्हाट इज डिस्टिचियासिस? डिस्टिचियासिस इज व्हेन देयर इज एक्स्ट्रा रो ऑफ आई लैशेस. डोंट कंफ्यूज बोथ ऑफ दीज विद एंट्रोपियन. एंट्रोपियन इज inward rolling of eyelids. All these three have been asked in your FMG exam. And you can also see that there is pannus. Pannus is infiltration along with vascularization. All these things go in sync with that of one disease, and that is your trachoma. Diagnosis is trachoma. देख पा रहे हो? Trichiasis is misdirected eyelashes. This is your definition of trichiasis. Miss नहीं करेंगे, note कर लेंगे इसको. All right. Now next is male is there, teenager visits IOPD with parents, complains of itching both eyes, which is more common in summers. ये क्या लग रहा है आपको? These are your cobblestone papillae. Next is your pseudogerontoxon. What is pseudogerontoxon? As you can see, this is peripheral corneal opacity. उसके बाद next is you can see Maxwell-Lyon sign. This is thick ropey discharge. देख पा रहे हो? Thick ropey discharge आ रहा है आंख में से. And next is, last is Horner Tranta spots. These are mucoid nodules which are present at the limbus. Don't confuse Horner Tranta spots with that of Herbert Pitts. Herbert Pitts are cicatricial scars at the limbus. देखेंगे, देख रहे हो, ये cicatricial scars हैं limbus पे, but ये है mucoid nodules at the limbus. So there is a difference between Horner Tranta spots in vernal keratoconjunctivitis and Herbert pits in trachoma. All right, now what is the etiology of such a condition? इस condition की etiology बताओ. क्या लग रहा है, दोनों आंखों में कुछ फर्क लग पा रहा है? बताइए जल्दी. प्यूपिल देखो, आईलिड देखो, ये देखो प्यूपिल देखो छोटा है, ये ठीक है, और आईलिड देखो थोड़ी सी ड्रूप कर रही है, ये ठीक है. क्या लग रहा है, क्या हो सकता है ये? हाँ जी, यस यस यस. और ऐसे लग रहा है आंख थोड़ी अंदर को गई हुई है, और ये तो ठीक लग रही है. चलो 3 क्लूज दे दिए, बताइए अब. Boys and girls, this is your Horner syndrome in which there is enophthalmos. However, this enophthalmos is pseudo-enophthalmos. There is ptosis. Ptosis is not full, it is partial ptosis due to paralysis of the Mueller's muscle, which is supplied by sympathetic fibers. And there is meiosis, pupillary constriction. And there is anhidrosis as well. Anhidrosis is loss of sweating of half of the face. Now, this is what I have just told you. I'll just slide on one side so that you are able to take the screenshot. Okay. What is the etiology of this condition in adults? It is due to Pancoast tumor. In children, it is due to difficult delivery, due to fracture of the clavicle, which will compress upon the sympathetic fibers, because sympathetic fibers passes through the tip of the lung and the clavicle. And during fracture of the clavicle, it will get compressed here due to Pancoast tumor. Pancoast tumor is the tumor of the tip of the lung, and it will compress the fibers against the intact clavicle in adults. So it will lead to damage to sympathetic fibers, hence leading to Horner syndrome. All right, coming over to the end of the session. Again, in the last 5 MCQs, Jones procedure, big procedure, quicket procedure, which surgery? Entropion. Entropion is inward rolling of eyelids, not eyelashes, eyelids. Okay. VY operation, Z-plasty, medial conjunctivoplasty. Ectropion, outward rolling of eyelids. Acute painful swelling at the lid margin, which is associated with refractory error in child. See, there's a difference. Agar swelling lid margin pe hui, you will go for stye. Most common organism in stye is Staph aureus. But agar आपकी स्वेलिंग अवे फ्रॉम द लिड मार्जिन हुई और वो पेनलेस हुई और लंबी, पेशेंट बोलेगा जी 1 महीने से है जी, 2 महीने से है जी, 3-4 महीने से है जी, क्रॉनिक हो गई ना, उसको हम बोलेंगे केलेजियन. चेलेजियनी, केलेजियन, प्यार से बोलेंगे केलेजियन. ओके. ऑल राइट, आई वाज श्योर दैट यू गॉट इट करेक्ट. ऑल राइट, सो दिस इज द एंड ऑफ आवर सेशन. And it is my pleasure to come online and have one-to-one interaction with you guys. I hope you enjoyed the session. The video will be available here on Medway's YouTube channel. You can anytime visit this short video in which I have tried to touch as many topics as I could in 1 hour of the time that was provided to me. And if you have any doubts, any queries, you can get back to me. I have provided with my WhatsApp number. Do give me your feedbacks. Do let me know in the comment section or share it with your friends. And yes, any of your feedbacks will be most welcome. And in the last, I would like to tell all of you that no exam is impossible to crack. कोई भी exam impossible नहीं होता. It's just that it needs to have a right approach. अगर आपकी अप्रोच करेक्ट है ना, तो जितना मर्जी डिफिकल्ट पेपर आ जाए, जितना मर्जी डिफिकल्ट एग्जाम हो, आप क्रैक कर पाएंगे. और एक चीज हमेशा याद रखना, आपके बहुत सारे सीनियर्स होंगे, कुछ लोग होंगे जो पहले पास कर चुके हैं, या कुछ सीनियर्स होंगे जो अभी भी तैयारी कर रहे हैं. वो आपको बोलेंगे अरे तू इतने 19 सब्जेक्ट क्यों पढ़ रहा है, सिर्फ 12-13 सब्जेक्ट करके चले जाना. अब मेरी एक बात सुनिए, अगर आप 12-13 सब्जेक्ट करके जा रहे हो, 5-6 सब्जेक्ट्स आप ऑलरेडी छोड़ के जा रहे हो, तो उन 5-6 सब्जेक्ट्स में से अगर 70-80 क्वेश्चंस बनते हैं, तो यू आर ऑलरेडी प्रिपेयर्ड फॉर ओनली 220 MCQs. तो यू टेल मी, विल इट बी इजी टू स्कोर 150 आउट ऑफ 220 मार्क्स, or it will be easy to score 150 out of 300 marks? It will be easy to score 150 out of 300 marks ना. तो why you are leaving a few subjects, ये सोच के कि अरे वो छोड़ दो, उसमें से कोई आ गया तो कर लेंगे. प्लीज इसको लक पे नहीं छोड़ना, सारे सब्जेक्ट्स को टच करके जाना है. अगर कोई 3-4 सब्जेक्ट मान लो आप रिवाइज एंड तक नहीं कर पाया, रह गया, बिल्कुल ही अनटच रह गया, तो अनटच करने से अच्छा उसका रैपिड रिवीजन हमारा आप देख के चले जाना. पूरा सब्जेक्ट छोड़ने से मच बेटर है कि हमारी रैपिड रिवीजन देख के चले जाना. यू विल स्टिल हैव गुड नंबर ऑफ क्वेश्चंस जो कि आपके ठीक होने की उम्मीद होगी, है ना. सो विद दिस, थैंक you very much. It was all my pleasure, and I hope to see you soon in Medway classroom on 19th of December. Then I'll be coming there face to face, and we are going to start the session at 9 AM sharp, and we are going to do it till 6:30 PM, जिसमें मैं 90% of the ophthalmology आपको करवा दूंगा. ठीक है जी, चलिए, thank you very much. Good night. Take good care of yourself, and yes, let's be in touch. Bye bye.